Hello, everyone, and welcome to neuro-radiology workshop. The workshop is aiming to develop a problem-solving approach to neuroimaging in general. The target audience are neurologists, neurology residents, junior radiology residents, as well as ER physicians. Let me start by discussing and introducing the basic MR sequences that you're going to see in almost every single MR case, starting with the T1, the T2, the FLAIR, fluid inversion recovery images, and the diffusion weighted images. We use the T1 for anatomic correlation and localization of the lesion. We use the FLAIR and the T2 for identifying abnormal processes and pathologies. This is primarily because pathology in general has excessive fluid within, may that be an infection, an inflammatory process, a neoplastic process, etc. And fluid represents itself within the parenchyma as high signal intensity, so it would be easy to identify against the relative dark background of the white matter that we see on both T2 and FLAIR. FLAIR has the extra advantage of having a dark CSF signal intensity, hence the NERM fluid attenuated inversion recovery, while T1 has high signal intensity CSF signal. The low signal intensity of the fluid within the ventricles and the subarachnoid spaces on FLAIR gives it the advantage of identifying subtle lesions abutting these spaces, meaning periventricular and subcortical areas, which we often need to identify subtle demyelinating processes, such as in MS. The diffusion sequence is a very short sequence. It takes about 30 to 40 seconds, and it aims to detect the restricted water molecule movement. Water molecule moves freely within the brain parenchyma along the various neurological tracts, and the restricted movement in these tracts is reflected as high signal intensity. Originally, it was aimed to be a sequence that detects early onset ischemia. However, later on, we also identified that such feature of restricted diffusion is also seen in other acute processes, such as active inflammatory processes, infectious processes, and even in some of the neoplasias. Our case today, it's an anonymous case. We're not going to give any history or clinical information or demographic information. The upper two images are FLAIR images, and the bottom two images are the diffusion images. So let's basically identify the findings on these images. The findings are primarily that there are multiple high signal intensity foci, some of them reflecting restricted diffusion. They involve both white matter, subthalamic regions, as well as gray matter. There is hydrocephalus. There is cerebral edema with effacement of the cortical sulci and high signal intensity sulci as well. There is abnormal signal intensity along the edges of the ependymal lining with restricted diffusion within the ependyma itself. These are the main findings. So what could this represent? Well, let's enumerate the general categories. This could be of ischemic or infarction nature, a demyelinating process, a neoplastic process, an infectious process, or maybe even vascular or traumatic etiologies. So let's tackle these one by one. Starting with ischemia, when people talk about ischemia, they talk about classic appearance of arterial infarction. And often you see in textbooks the classic appearance of gray-white matter, effacement, and low attenuation that is clearly demarcated and marginated within the anterior cerebral or middle cerebral, posterior cerebral, or even basal ganglia distribution. And this is the classic appearance. However, this is not how it usually starts. The way ischemia appears at early neuroimaging is actually detecting the presence of the thrombus within the artery as high signal density, high density within the artery. This is the dense MCA sign representing the blood clot filling the M1 segment of the middle cerebral artery in these two different patients before identifying any significant parenchymal changes. Later on, as the parenchymal damage starts to happen, you start losing the gray-white matter differentiation around the basal ganglia. Here on the right side, you have the head of the caudate, the lentiform nucleus, the anterior limb, posterior limb, the genio of the corpus callosum, the genio of the internal capsule, as well as the thalamus. On the left side, you've lost the head of the caudate, you lost most of the lentiform nucleus, ill distinction between the gray-white matter differentiation along the edges of the anterior limb of the internal capsule. You also identify that the sylvian fissure is smaller in size, and the insular ribbon, which is usually outlined by the insular cortex with the underlying external capsule, has been lost. So you've got the vanishing or disappearing basal ganglia and the loss of the insular ribbon. These findings are of early infarction, secondary to the presence of a thrombus or an occlusion in the feeding artery. Later on, this will become more obvious and extend into the deep white matter. Now, if you don't have a classic appearance or you don't see this on CT scan, you may result to doing diffusion images and then perfusion images and looking for a mismatch. In this case, there's no strong mismatch. Actually, the perfusion defect matches the diffusion defect, which tells you that this is dead tissue. However, if the perfusion defect is much larger, then this tells you that the diffusion area is what represents the dead tissue, while the perfusion defect represents the dead tissue plus the penumbra or the salvageable brain if you intervene at the right time with the right selection of patient population. As we get an established stroke with clear demarcation, loss of gray-white matter, differentiation, effacement of the sulci, maybe mild mass effect of the ventricular system, this usually, with the proper medical management, regresses with time because of resolution of some of the edema and ends with a smaller central infarction. However, in some of the cases, this may progress significantly into involvement of other territories and turn into a malignant behavior, resulting in malignant infarction with secondary massive infarction of the whole hemisphere, midline shift, transtentorial herniation, sulfosine herniation, sulfosine herniation, compression of the ventricle, and these patients usually have worse outcome and maybe eventually demise. Other entities that may simulate ischemia, particularly central ischemia around the basal ganglia and thalami, is what you see in carbon monoxide poisoning with hypoxia and infarction of the thalami and the internal capsule. This may also extend to involve the lentiform nucleus. This also simulates the similar appearance you see in internal cerebral vein thrombosis. With thrombosis of these veins, you get congestion and venous infarction of the thalami and the basal ganglia. Obviously, dural sinus thrombosis may also be seen with contrast-enhanced images as the thrombus within the venous system here at the confluence of the sinuses or along the transverse sinus. This is the sausage sign. This is the delta, the empty delta sign. And these venous infarctions have high tendency to turn into hemorrhagic infarctions in up to 30 to 40% of the cases. Just for sake of completion, Creutzfeldt-Jakob disease may have similar distribution of basal ganglia and thalamic high signal intensity. However, the differentiation between the gray-white matter is preserved, and obviously the clinical scenario is completely different. Cortical ischemia with restriction diffusion along the cortices and the basal ganglia is often seen in case of hypoglycemia. post-ictal status, and in posterior reversible encephalopathy syndrome, such as cases of eclampsia and preeclampsia. However, these situations are usually reversible because they are transient. They recover gradually over 3 days. Repeat examination with proper treatment after 3 to 4 days may show regression of most of these findings. Some of the cases, if not intervened with proper medical treatment early, may result into small areas of infarction and ischemia in the same distribution, resulting in areas of parenchymal gliosis. However, these are usually transient and they recover within 36 hours with proper medical treatment. Now, it is true that one of the giveaway diagnoses is that these lesions in ischemia are usually territorial, whether it is within the distribution of MCA or along the watershed distribution. However, what makes images rather confusing is when you give contrast for infarction because of the known phenomenon of delayed luxury perfusion. You get meningeal enhancement, you get punctate pattern of parenchymal enhancement, solid well-defined and smudgy enhancement, as well as delayed vascular enhancement. This could be confusing and may result into misinterpretation if not taken in consideration the clinical scenario as well as the findings in the rest of the images. So back to our case, is this a case of ischemia? Well, there's non-specific arterial territory. There is hydrocephalus, there is abnormal enhancement of the edges of the ependymal lining with restricted diffusion within the ventricle, and there is bright sulci, and these are not findings that you commonly see with ischemia. So it is rather unlikely. Moving on to the next possibility of demyelination. When people talk about demyelination, they mention MS in its classic appearance with multiple high signal intensity foci distributed along the ventricular system with perpendicular orientation of these lesions to the long axis of the adjacent ventricular system. Notice they are standing on end in relation to the long axis of the ventricle. Similarly, the involvement of the corpus callosum, particularly the undersurface of the corpus callosum. The lesions may demonstrate restricted diffusion in the acute phase in active disease. They may also involve deep white matter in the internal capsule, sometimes even identified in the thalami, as thalami also involve a smaller percentage of white matter tracts. The enhancement is classically of an incomplete ring pattern of enhancement, but sometimes give you a complete ring. There's enhancement of periventricular lesions. Even larger lesions lack mass effect because these are pseudo masses. These are not masses. Hence, there's no mass effect on the adjacent ventricular system. There's no effacement of the sulci or bulging of the cortex. This is the classic appearance of demyelinating plaques. A classic example of tumefactive MS, large lesions with incomplete ring pattern of enhancement and absolute lack of mass effect. A classic case of Barrow's concentric sclerosis with an onion ring appearance, minimal amount of surrounding edema, smudgy pattern of enhancement with no significant mass effect. Lack of mass effect is a hallmark of these large lesions. Now, in comparison, there are other demyelinating processes that are rather not following the same pattern of MS distribution and obviously have different clinical representation. ADEM, often seen after vaccination or infections, gives you large, confluent, asymmetric distribution of deep and subcortical white matter, often of posterior distribution, less likely involving the basal ganglia, mainly in the posterior distribution, subcortical and deep white matter, and may give you subtle restricted diffusion. Pattern of enhancement is rather subtle and uncommon. CADA-cell, which is the cerebral arterial dominant arteriopathy with subcortical infarcts and leukoencephalopathy, give you diffuse, irregular, fairly symmetric, high signal intensity lesions of confluent large nature, involving the deep and the subcortical white matter with relative sparing of the periventricular white matter and the corpus callosum. SUSAC have the classic syndrome with visual and auditory impairments, and classically involving the corpus callosum with large cotton ball lesions involving the body of the corpus callosum and the splenium. These lesions are within the center of the corpus callosum and not classically involving the undersurface, which is often seen in MS. Migraine give you rather non-specific punctate high signal intensity lesions that are scattered here and there with no specific distribution. Simulated chronic white matter ischemia, however, the chronic white matter ischemia are usually larger, confluent, and abutting the posterior horn of the body and the occipital horns of the lateral ventricles, also involving the deep white matter and the basal ganglia, with an element of generalized reduction of the brain volume, because usually this represents chronic white matter ischemia, multiple minor infarcts, hypercholesterolemia, hypertension, diabetes, etc. ALS has a unique feature of involving the motor, the tracts of the motor cortex. This is the motor cortex, this is the central sulcus. So this is the primary motor cortex, and this is the primary sensory cortex. White matter high signal intensity, homogeneously and diffusely involving the white matter from the level of the motor cortex superiorly, from the motor gyri superiorly, extending in very clear, sharp pathways along the corticospinal tracts down to the brain stem and located within the anterior part of the cerebral peduncles. This is the demyelination of the corticospinal tracts in amyotrophic lateral sclerosis. So is this a demyelinating process? Well, there's again hydrocephalus, abnormal restriction and diffusion within the ventricles and along the edges of the ventricles. There are bright sulci. There's gray and white matter involvement, which is all are not classic for demyelination. So maybe not likely. Moving on, next category, could this be neoplastic? In neoplasia, here I aim to develop an approach, as I said, for identifying lesions and locating them. So in neoplastic processes, in mass lesions, you want to identify, is it intraaxial or extraaxial? Extraaxial lesions push the brain parenchymal cortex inward. You can see the buckling or inward displacement of the gray matter. You can see the gray matter being displaced inward. You can see that as it is displacing the brain parenchyma, it enlarges the subarachnoid spaces at the margins, like this CP angle lesion with enlarged CSF spaces. As the lesion compresses the brain stem, the cerebellar hemisphere, and deforms the fourth ventricle. And you can see in this interhemispheric lesion how the cortex is being displaced away from the lesion, and the lesion is completely surrounded with subarachnoid space. So this is an extraaxial lesion. In comparison to the intraaxial lesion, the lesion is completely surrounded with brain parenchyma. The brain parenchyma goes around it like a claw or a cap. Even in this small lesion, you can see that the cortex is surrounding the lesion. The lesion is completely within the brain parenchyma. After that, you may localize the lesion to a particular lobar distribution. Then identifying the edema that is resulting from the lesion. Mass lesions within the brain, may that be a neoplastic process or an infectious process or even a hematoma, incite what is known as vasogenic edema. Vasogenic edema is edema of the white matter, purely white matter. It interdigitates itself as fingers in gloves into the depth of the gyri. It spurs the cortex itself. To the contrary, cytotoxic edema, which is classic for infarction, is arterial territory distribution with clear demarcation involving both gray and white matter with loss of the gray-white matter distribution. It wipes away the gray-white matter distribution. This is the cytotoxic edema that we see in infarction. This is the vasogenic edema that we see with lesions within the brain parenchyma irritating the brain parenchyma. Later on, you go with mass lesions to identify the mass effect as it compresses the ventricular system, effacing the overlying sulci, displacing the brain parenchyma, resulting in uncal herniation or subfalcine herniation. In these cases, these two cases, this is an abscess causing extensive edema with effacement of the sulci and compression of the ventricle, while this one is a tumefactive S. It's a pseudo lesion, it's a pseudomass, as indicated by the preservation of the sulci and the lack of mass effect. Multiplicity of the lesions usually go with infectious and neoplastic processes. And the nature of the lesion, the texture of the lesion is important to identify, as it could be purely cystic, could be solid lesion, primarily solid with areas of necrosis, and could be heavily calcified, and each one of these features may indicate a particular entity. The signal characterization and the behavior with contrast enhancement and diffusion is important in further fine-tuning your diagnosis, as in this case of lymphoma, within the basal ganglia, as demonstrated by the low signal intensity on T2, the restricted diffusion, and the intense enhancement. So, does our case represent a case of neoplastic process, whether it is metastatic or diffuse neoplasia? Well, unlikely, because we talked about hydrocephalus as a finding that we don't often see in neoplasia unless there is ventricular metastatic drops. The high signal intensity within the ventricle indicative of a restricted diffusion in the ventricular system, which is not often seen in neoplasia. There is no mass effect and there's no vasogenic edema, so maybe unlikely to be of neoplastic nature. So moving on to the next category, which is infection. When we talk about infection, we talk about meningitis primarily, and there are three different types of meningeal enhancement. There is the leptomeningeal enhancement, which indicates enhancement of the pia mater and the arachnoid mater, as it is seen by the enhancement of the sulci, the meningeal reflections within the depth of the sulci. This is often seen in infections, and usually it is smooth in nature. However, if it is leptomeningeal enhancement with nodularity, then you may consider meningeal carcinomatosis or meningeal metastasis. Now, the other type is pachymeningeal enhancement, which is enhancement of the dura mater, and you can see that it bridges over the cerebral cortex. It does not go into the depth of the sulci as it is seen in the leptomeningeal pattern. This is often seen in cases of intracranial hypotension or violation of the meninges by doing a surgical procedure, a craniotomy or a VP shunt, or even a lumbar puncture. Notice the intense enhancement and the thick enhancement of the tentorium, cerebellar tentorium. The basal meningeal enhancement is enhancement of the basal meninges and the cerebellar tentorium with invasion of the undersurface of the basal ganglia. This is an intense pattern of enhancement that is often seen in granulomatous diseases, granulomatous infectious diseases such as TB, or non-infectious diseases such as sarcoidosis and histiocytosis. With meningitis, you see high signal intensity of the sulci. The CSF within the sulci is very proteinaceous, reflecting high signal intensity. The other differential diagnosis for high signal intensity sulci on FLAIR is subarachnoid hemorrhage, because both will result in proteinaceous CSF. Now, other possibilities that may simulate this appearance, although not classic, are hyperventilated patients in ICU because of high oxygen tension within the cerebral CSF, and the possibility of having a cerebral infarction or a tumor with leaking of protein content into the overlying sulci, but that will give you localized areas of CSF high signal intensity, not as diffuse as it is seen in these cases. Obviously, when you give contrast, you see the classic leptomeningeal enhancement of meningitis with some enhancement in the basal ganglia in this case. Complications of meningitis, such as empyema, seen with the enhancement of the dura mater and the extension into the interhemispheric valves, or development of intracranial abscesses are not uncommonly seen if not treated early. This slide aims to demonstrate 4 different categories. The upper row is contrast-enhanced T1 weighted images. The lower row is the T2 weighted images. First case represent a smooth ring pattern of enhancement with minimal mass effect and low signal intensity in the center. On T2, it shows high signal intensity in the center with well-defined capsule and minimal degree of enhancement. This represents bacterial abscess. The lack of minimum increased signal intensity around it, minimum edema, is due to the start of antibiotic therapy. So this is the classic appearance of a bacterial abscess. Smooth ring enhancing pattern with high signal intensity center on T2 and clearly demarcated capsule. Usually surrounding edema is seen in the early stages and the edema regresses with treatment. The second case shows another ring enhancement pattern. However, it is not smooth. It is rather regular and shaggy, ill-defined, and with areas of satellite lesions. The center of the lesion is low signal intensity as compared to the bacterial abscess. It is low signal intensity because it is tenacious, it is thick, it is inspacated, it has lower water content. This is mycobacterial. This is TB abscess. Another reason for the low signal intensity center on T2 is the presence of hyphae with microcalcification within. Here, there is extensive edema around it, vasogenic edema, because the treatment has not been started yet. The third case is actually a mass lesion that shows an amorphous, irregular, ugly pattern of solid enhancement with areas of central necrosis. The central necrotic areas show high signal intensity on T2, and the solid lesions remain of parenchymal signal intensity. This is glioblastoma multiforme with surrounding vasogenic edema. The last case is multiple sclerosis of tumefactive type, showing the large pseudo lesion, the lack of mass effect. The sulci are patent, there's no mass effect, and there's a ring enhancement pattern, an incomplete ring enhancement pattern. So, by giving the contrast enhanced images and the T2 weighted images, you'll be able to differentiate the bacterial abscess from the tuberculous abscess, from glioblastoma multiforme as a neoplastic example, and MS. Diffusion weighting images may also be helpful in differentiating neoplastic from infectious processes. Both bacterial and mycobacterial abscesses may have central restricted diffusion because it has pus that is thick, proteinaceous with low water content, while neoplastic lesions will liquefy and necrotize in the center with high water content. This is why it will not show restricted diffusion. Now, as we speak about enhancement and ventricular involvement, here basically you've got hydrocephalus with high signal intensity edging the ependymal lining with debris fluid level or debris CSF level. With contrast, you can see the enhancement of the ependymal lining. On diffusion, on flare, you can see the high signal intensity within the CSF itself that reflects diffusion restriction. This is ventriculitis. Now, if we take an example of herpes simplex encephalitis, usually it starts within the limbic system, within the uncus, and it involves primarily the hippocampus and the parahippocampus. This is it on the T2 and the flare images with subtle restricted diffusion. As the disease progresses, if not treated early, it may involve both temporal lobes with extensive vasogenic pattern of edema. Eventually, it may also extend into the inferior aspect of both frontal lobes, as seen in this case on CT scan. So, back to our case, is this an infectious process? Well, there's gray-white matter involvement, which we see in infections. There's restricted diffusion, which we see in acute infections as well. There is cerebral edema with effacement of sulci. There is hydrocephalus with bright bright ependyma and some debris within the ventricular system that shows restriction, which goes with ventriculitis. There is the bright sulci, bright CSF signal intensity on flare, which we see with meningitis. So all these go with an infectious process. So yes, this is actually a case of meningoencephalitis with ventriculitis. So what I aimed from this presentation is to give an approach to problem-solving methodology in looking at neuroimaging, what you should do on your routine evaluation of your patient's images is the following. Number one, try to identify the findings that you see on the different types of images, and then categorize them into different categories. And based on these findings, see what goes with and what goes against each of these categories and put them in priority orders. So you have a short list of differential diagnosis and a likelihood of getting the exact diagnosis nailed down. Thank you very much. I appreciate your tuning in and attending this presentation, and hope to see you soon in other lectures about various neuroimaging techniques and presentations in future lectures. Thank you very much. Appreciate it.